diagnostic and therapeutic challenge.
Good morning, one and all present here. My topic for today is an atypical manifestation of ocular toxoplasmosis, a diagnostic and a therapeutic challenge. Its cursor is not moving. Ocular toxoplasmosis is one of the most common cause of infective posterior uveitis worldwide, and these are all the atypical forms we know. And the exact estimation of the incidence of them is not known or underestimated because of unaware of the atypical forms, is because it's a clinical diagnosis. Toxoserum IgG or IgM is not done, and PCR is not feasible in these cases. Most of the time, it's often diagnosed as idiopathic because the other eye findings are not highlighted or overlooked. The diagnosis of atypical toxo is highly significant to avoid the recurrence and life-threatening complication. Our study is a retrospective study in which atypical patients who had atypical lesions who were tested positive for either IgG or IgM serum antibodies who showed positive response to anti-toxo medication, that is standard triple therapy was given for all immunocompetent patient, and intravitreal clindamycin was given for an immunocompromised patient. Improvement in the disease activity or an increase in the best corrected visual acuity has been recorded. And comprehensive history, visual acuity, and anterior segment, posterior segment, and multimodal imaging were done whenever necessary. A total of 15 eyes of 12 patients who met the inclusion criteria were diagnosed with atypical toxoplasmosis. Our study has a male preponderance with the age range from 21 to 66 years. The BCVA ranged from 5/60 to 6/6. Majority of the cases were neuroretinitis, which had 26.67%, followed by posterior scleritis, exudative RD, vasculitis, multifocal toxoplasmosis. Majority of our patients were immunocompetent in our study. An IgG ranged from 3 to 650 international units. Our first case is a 47-year-old female who presented with vitritis, disc edema, and subretinal fluid at the macula. Patient was already treated elsewhere with oral and topical steroids, and she had come with the recurrence. Other eye examination showed a CRA patch at the infratemporal quadrant. An atypical toxo was suspected and started on anti-toxo medication. Our second case was a 53-year-old female who presented with vitritis and disc edema. This patient was 3 months post-op, treated as a recurrent post-op uveitis, and the vitritis was increasing with the fluid collection in the subtenon space. And patient was treated with anti-toxo medication for 6 weeks, and post-treatment, visual acuity improved to 6/9. And the next patient was a 47-year-old male who had a multifocal retinitis patch between the arcades with an arthritis below. And other eye showed a multiple CRA patches. So in this, the patient vitritis was very less, so we suspected an immunocompromised state, and it was positive. Patient was a HIV positive, and intravitreal clindamycin was given weekly once, and then along with the heart therapy in the general hospital. And this is another case where he was a 45-year-old male who presented with uveal effusion syndrome, where patient had an exudative retinal detachment. Along with triple therapy was started, along with sclerostomy was done for this patient. This is a 45-year-old male who presented with scleritis in both eye. When we take a close look at the fundus, there was a perifoveal speck of whitening seen in the macular area. OCT showed PAM with an ellipsoid disruption of the ellipsoid zone suggestive of a drifter. Patient was, his IgG toxo was 450, and he was treated with anti-toxo medication, and review awaited. And this is a 33-year-old male who presented with multiple whitish creamy lesions suggestive of APMPPE. He had contact with pets, and his other eye had an CRA patch at the infratemporal quadrant. Though APMPPE is a self-limiting disorder, to avoid recurrence in this case, patient was started on anti-toxo medication, and the patient is post 6 weeks, patient vision is 6/6. Until now, there was no recurrence. To conclude, the diagnosis of atypical toxoplasmosis can be made with a high index of suspicion. A typical or an atypical ocular presentation, response to anti-toxo medication, positive IgG or IgM serum antibodies, history of contact with pets, and positive PCR results from aqueous or vitreous humor. Any of the three criteria in this 5, we would call it as an presumed ocular toxoplasmosis. And our study highlights several atypical clinical manifestation of ocular toxoplasmosis. Also reveals the presence of rare conditions like PAM and Rifter. While atypical presentations are often seen in immunocompromised individual, our finding shows the immunocompetent patients can also have these atypical forms. Given the varied clinical presentation and challenges in confirming a definitive diagnosis, we propose a set of criteria for presumed ocular toxoplasmosis that can aid in identifying the condition in the absence of definitive PCR result. This approach will help guide us to appropriate treatment, improving the outcome for affected patients and to avoid decrease the incidence of idiopathic uveitis. These are my references. Thank you.
Thank you, thank you. I think very good presentation, but I think you had us confused, like, we always think like it's retinochoroiditis. Many patients had just deep choroidal lesions and, just depending on the scar on the other eye, you were treating them.
These are atypical forms, sir. The rare atypical forms which we found in our series.
And which were the patients, why were you injecting your patients who are immunocompromised and not your immunocompetent patients? Like, why is the reason you inject only that subset?
No, immunocompromised patients, we can't start them on the triple therapy because the steroids we have. So we prefer to inject intravitreal clindamycin. The other patient, they responded well with the oral treatment only, sir. So we didn't...
What is your oral therapy? What is your...
The standard triple therapy of trimethoprim sulfamethoxazole with oral steroids, 1 milligram per kg.
There are no side effects of these, no side effects of oral therapy because we prefer to give intravitreal in most of our cases.
So far we didn't find
all right, and how frequently do you repeat your intravitreal?
1 week.
1 week for how long? Till the time you see the activity?
Yes, activity response.
So usually it's how many weeks is what I want to know?
Usually
in average patients? 1 month?
3 weeks we have given for that immunocompromised patients, sir, along with the heart therapy.
So every week you are giving?
Every week. Depending upon the response we give it.
Yeah, because as Maran was saying, systemically most patients, if you start them on clindamycin, they develop a pseudomembranous type of colitis and diarrhea. Because quite a few of my patients do develop.
No, we didn't give systemic clindamycin. We gave intravitreal clindamycin.
So systemic therapy was only
only triple therapy.
Only triple therapy.
Yes.
So your take-home message is that 5 criteria. If a person fits into those 3 criteria, then it's a case of presumed
ocular toxoplasmosis.
Because the presentations were too varied, starting from deep choroiditis to vasculitis.
Yes, sir.
So which are quite rare.
Yes.
So nice presentation.
Thank you, sir.
What is your triple therapy? You said one was sulfa with trimethoprim, then steroids.
Double strength.
Yeah, Septran DS.
Septran DS, and then oral steroids with azithromycin.
With azithromycin you're using? You're using azithromycin?
Yes.
What is the dose of azithromycin you're using?
Initially starting 3 days we give 500 mg OD.
Yeah, they can also listen.
Starting 500 mg OD for a week we'll give. Later for 6 weeks 250 mg
Okay.
OD.
Fine. Good. Thank you so much. Thank you.